Herkese iyi akşamlar. Bugün Akciğer Sağlığı Yoğun Bakım Derneği'nin düzenlemiş olduğu yeni akciğer kanseri sınıflaması olan bu 9. versiyon olarak yayınlanacak olan TNM klasifikasyonunun tartışıldığı webinarımıza hoş geldiniz. Bu akşam çok önemli bir konuğumuz olacak. İspanya, Barcelona'dan Doktor Ramon Rami Porta konuğumuz olacak. Konuşmalar İngilizce olarak akacak. Bu nedenle İngilizce olarak dinlemek isteyenler bu programda kalabilirler. Ancak tercüme yayını dinlemek isteyen katılımcılarımızın hemen ekranlarının altındaki tercüme butonuna bastıklarında Türkçe olarak devam edeceğini buradan bildirmek istiyorum. Şimdi artık oturumumuza başlayabiliriz. Hi, good evening everyone. Welcome to our online webinar. We are here to learn into the latest updates in lung cancer staging, especially especially the forthcoming ninth edition of the TNM classification. Today we have a very important guest speaker, Professor Dr. Ramon Rami Porta from Spain. I would like to express our sincere gratitude to Professor Dr. Ramon Rami Porta for accepting our invitation on behalf of our society. This is an absolute honor for me to moderate this online webinar. First, I would like to pass the floor to the Dr. Celal Buğra, my co-chair, for his thoughts and introduce to our speaker.
Dear colleagues, first of all, thank you for joining our webinar. I would like to extend our thanks also to Lung Health and Intensive Care Society for organizing this event. So today, I want to introduce you Dr. Porta. Professor Dr. Ramon Rami Porta is a distinguished thoracic surgeon who has made a significant contribution to the field of the lung cancer over the years. He has worked in Barcelona and he has been attending a thoracic surgeon at Hospital Universitari Muta Teresa since 1989. From 2009 to 2016, he served as a chair of the International Association for the Lung Cancer Staging and Prognostic Factor Committee. His primary interest is the lung cancer staging, surgical treatments, and thoracic oncology era. Today, Dr. Porta will enlighten us on the new lung cancer staging proposal, including his valuable contribution to the new staging guidelines. Please, Dr. Porta, the stage is yours.
Thank you very much. I will share my screen. Okay. Thank you. So thank you very much, Drs. Günay and SEZEN, for your kind invitation to participate in this webinar. It's a privilege for me to discuss the new lung cancer staging with the members of your society. So let's see. I have no conflicts. And the content of my presentation will begin with an introduction, mainly on the database. Then I will discuss the innovations of the 9th edition TNM for lung cancer. I will discuss the practical implications. I will show you only a slide with a summary, and then I will end with the conclusions. So as an introduction, I will tell you that the new TNM classification of thoracic malignancies, lung cancer, thymic epithelial tumors, and pleural mesothelioma was presented in Singapore in September last year. At that time, the papers were not published yet, but Doctors Asamura, Roche, and Ruffini presented the lung cancer, mesothelioma, and thymic tumors TNM in that special session, in that meeting. Now I can tell you that the papers are already published. We have a paper with a database, and then 3 papers with the T, the N, and the M analysis, and the recommendations for innovations in the 9th edition. And finally, the stages paper, analyzing how we can assign the new tumor groups into the new stage groupings. So this is a slide just to look at the colors. You don't have to read it, actually. On the left, you see this pie, and the dark blue color is the number of patients that have been registered from Asia and Australia. It's nearly 60% of all the cases that we have for the 9th edition come from Asia or Australia. Then we have a good representation, about 25% from Europe, and then about 20% from North America, a few from South America, and just a very anecdotal representation of Africa and the Middle East. So in the central graph, you see the number of patients registered through what we call the EDC, which is the Electronic Data Capture System. That is the registration of all the data online. So doing this, it is very time-consuming, but the database is more complete, and there are more details about the tumors and the patients than if you do it with your own database. So here, by the EDC, we have China as #1 country to register cases. More than 12,000 patients were registered in this system. On the right, you have the number of patients registered by what we call batch data. So if you have a database with lung cancer patients, you can send it directly to the statisticians. They clean it up, and they will use your material. The only problem is that these databases were not created to study the TNM classification, many of them, and some of them lack the important items that we need to revise the TNM classification. So the data is not as complete as the data registered through the EDC system. On this side of the slide, you can see that Japan is #1 contributor, because the Japanese have a very long tradition of patient registration. So they have very good databases, and that they can be sent to the statisticians, and they can be used very well, and they are really useful for the analysis of the different TNM descriptors. So for this 9th edition database, we got more than 124,000 patients. But as you can see here, there is a series of exclusions, mainly lack of information on histologic type, survival. There are tumors that are not non-small cell lung cancer, or there is no stage, or any other lacking information that we think it's important to analyze and to revise the TNM classification. So after the exclusions, we have 87,000 patients that have complete data, all the data that we need to revise the TNM classification. Most of these patients have non-small cell lung cancer, as it could not be otherwise, but others have neuroendocrine tumors or cancers with multiple lesions, synchronous tumors, that will be very useful to validate the recommendations that we issued for the 8th edition regarding the classification of lung cancers presenting with multiple lesions. And then we also have other tumors. If we compare the databases of the 7th, the 8th, and the 9th edition, we see that the number of lung cancer patients is about the same, very similar. We have 84% non-small cell lung cancer, but more than 5,000 patients with small cell lung cancer and other cancers. But the most important thing, the innovation of the 9th edition TNM, is molecular data. We have nearly 10,000 patients with non-small cell lung cancer that have some molecular data, which is being analyzed right now. Now we have already finished the core papers, the T, the N, the M, and the stages papers. Now we can concentrate on how to improve prognostication by adding molecular data to the TNM classification. And I hope that in the next few months, we will be able to come up with something combining a TNM and molecular data. So nearly 1,400 patients came from Turkey, and this is a very good contribution, but I think, honestly speaking, that you can do better. You are a large country with many thoracic surgeons, many oncologists, many pulmonologists that deal with lung cancer patients. So I would like to encourage you to participate as much as possible in this long-standing staging project from the International Association for the Study of Lung Cancer. I can only say thank you very much for your contribution, and I hope that you will keep contributing your cases to the ISLC database for the 10th edition and beyond the 10th edition of the TNM classification. So, what are the innovations of the 9th edition? First of all, in the T component, what we did was to use the 8th edition categories from T1A to T4 and analyze the survival of patients with these tumors and these categories in the patients of the 9th edition. And you can see here in these graphs, on the left, the clinical T, on the right, pathologic T, that the survival curves separate very well. Here, T2B and T3 in the clinical staging and in the pathologic staging are very close, but differences still are statistically significant. So, because the 8th edition T categories work well with the 9th edition patients, we opted for not changing anything. So we will keep the 8th edition T categories for the 9th edition. There will be no changes. You can see here that there is all the comparisons with the different T's are statistically significant, and there is the expected degradation of survival in the 5-year estimate from 91% in T1A to 37% in T4 in the clinical staging, and similar numbers in pathologic staging. So there are no changes in the T component. However, we did specific analysis on this particular descriptor of the T3 category, the invasion of parietal pleura or chest wall. And the results are here. On the left, you can see the analysis of clinical T3. And you can see that the blue line, which is chest wall or parietal pleura, aligns very well with the red line, which is the survival of other T3 descriptors. And these two lines, which are very similar, and the 5-year survival estimates are almost the same, 59%, 58%, separate very well from the green line, which is T4, the survival of clinical T4, which is 47%. So there is a good separation between these two curves and this one. However, when we do the same analysis in pathologic staging, that is that the parietal pleura and the chest wall invasion have been confirmed histopathologically by the pathologist analyzing the resected specimens, we see a different thing. The blue line, which is the chest wall and parietal pleura invasion, aligns well with the T4 tumors, not with the T3. So, in pathologic staging, we could say that parietal pleura and chest wall invasion has a T4 prognosis, better than a T3. However, when there are discrepancies between the clinical and the pathologic staging, the decision is not to change anything, because it might be confusing if we have different descriptors for the clinical and the pathologic T3. So parietal pleura and chest wall invasion will remain in the T3 category. But I think it is useful for our patients and for us to know that if a patient has undergone resection and the tumor is invading the chest wall or the parietal pleura, the prognosis is worse than the T3 category, which is the category that the tumor has. Okay, so I think this is a point that will deserve further analysis in the 10th edition of the TNM classification. Regarding the N component, you can see here that the 4 N categories, N0, N1, N2, and N3, work very well both at clinical and pathologic staging. The survival curves separate very well. There is no crossing of the curves, of the lines, and you can see here that there is a degradation of survival, worsening of the 5-year estimate as the N increases. N0, 76%, N3, 25%, and similar data survival in the pathologic staging. However, probably you remember that in the 7th edition and in the 8th edition, we tried to quantify nodal disease because quantification of nodal disease is an N descriptor in other tumors, namely the esophagus and the gastric cancers have the N categories based on the number of lymph nodes involved. So for the 7th edition, what we did was to analyze the N categories depending on the number of nodal zones involved. A zone in the 7th edition was a group of nodal stations that were close together. For example, the upper mediastinal zone, the subcarinal zone, the inferior mediastinal zone. So the more involved zones, the worse the prognosis. And we noticed that multiple N1 zones, N1B, had the same prognosis as single N2 zone. So this was a finding that was only identified at pathologic staging. All these patients here had undergone resection and had a clinically acceptable lymphadenectomy. For the 8th edition, we did the same thing, but counting the involved nodal stations. And we found the same findings. The more nodal stations involved, the worse the prognosis. From single N1, 58%, to multiple N2, 36%. And here we found that multiple N1 stations had the same prognosis as single N2 without N1. Again, these findings were from pathologic staging and could not be validated at clinical staging. However, for the 9th edition, we found a very simple way to quantify nodal disease that could be validated both at clinical and pathologic classification. And this quantification was the division of N2 into N2 single station, or N2A, and N2 multiple stations, N2B. And you can see here that the green line is N2A, single N2, and the yellow is multiple N2, N2B. They separate well between them, and they also separate very well from the other N categories. And the same happens at pathologic staging. N2A and N2B are really separate. They have different survival, 51% and 40%. The same at clinical staging, 42% and 31%. So the decision of the committee was to propose the division of N2 into N2A and N2B. N2A, single N2 nodal stations, N2B, multiple N2 nodal stations. For the M component, there are findings that are the same as the 8th edition and others are different. For example, on this graph, the blue line is M1A, intrathoracic metastasis, and the red line is single extrathoracic metastasis. And they had the same prognosis in the 8th edition, and they still have the same prognosis in the 9th edition. So there are no changes in M1A and M1B. However, the green line and the yellow line have different prognosis here. The green line was multiple extrathoracic metastasis in a single organ, and the yellow line was M1C, multiple extrathoracic metastasis in several organs. So having multiple extrathoracic metastases in one or in several organs had the same prognosis in the 8th edition. But in the 8th edition, we had about 5,000 patients with clinical metastasis, and here we have nearly 15,000 patients. So I think that this is closer to reality, because having multiple metastases in a single organ or system is not the same as having multiple metastases in several organ systems. For the 9th edition, we will use the expression organ system or organ systems and not only organ, to avoid the confusion that sometimes occurs in patients who have several bone metastases, for example, in the femur, in the ribs, in the skull. So are these bones organs? No, they all belong to the skeletal system. So it's the bony system. So having multiple metastases in multiple bones only, it will be M1C1. We will divide the 8th edition M1C into M1C1, multiple extrathoracic metastases in one organ system, and M1C2, multiple metastases in multiple organ systems. For example, the skeleton, the liver, the brain, the kidneys, or the adrenals, right? So, multiple extrathoracic metastases have now two M1 categories, M1C1 and M1C2. So these are the proposed changes. For the T, there will be no changes. For the N, N2 will be divided into N2A, single N2 station involved, and N2B, multiple N2 stations involved. And the M will have the subdivision of M1C into M1C1, multiple extrathoracic metastases in a single organ system, and M1C2, multiple extrathoracic metastases in multiple organ systems. So these changes will condition the stages, because as you can see here, this is not to read, this is just to have a visual impression of what the recursive partitioning does when we analyze the tumors with different prognosis. And here we have excluded all the M1 patients, and here the system analyzes first the tumors with N0, and then T1, T2, T2B, T4, and then N1 to T3 to N3, N1, N2, N3, and so on. And these final boxes here are tumors that have different prognosis from their neighbors. And we have to assign these tumors to certain stages. And the tumors in red color are the new tumors that have been created by the fact that N2 has been divided into N2A and N2B. We didn't have T1 N2A in the 8th edition, so this is a new tumor. We didn't have T2A N2A, so this is a new tumor that we have to assign to a certain stage. And after many discussions, we decided on this model, which you can see on the right hand of the slide. On the left, you have the old model for the 8th edition, which will be useful to compare both models of stages. So I will try to navigate you through all these changes. First of all, the most important change in the 9th edition is the subdivision of N2 into N2A and N2B. So in the 8th edition, T1 N2 was 3A. But we found that in the 9th edition, T1 N2A had better prognosis than stage 3A. So it has similar prognosis of stage 2B. So we have assigned T1 N2A to stage 2B. Stage 2 and N2 was stage 3A. But here in the 9th edition, we have found that T2 with N2B has worse prognosis than stage 3A. It has similar prognosis to stage 3B. So we have assigned T2 N2B to stage 3B, not to stage 3A. Only T2 N2A remains in stage 3A. In T3, T3 N2 was stage 3B in the 8th edition. But here, in the 9th edition, T3 N2A has better prognosis than stage 3B. It has prognosis similar to stage 3A. So we have assigned T3 N2A tumors to stage 3A. And there are no changes in the M1 because both subcategories of M1C, M1C1, and M1C2 remain in stage 4B. So you can see here the survival graphs of the clinical stages. They are very similar to those of the 8th edition. You can see the survival curves separate. There is a degradation of survival from 82% for stage 1A to 7% for stage 4B. This is clinical staging. And all comparisons are statistically significant except one, the comparison between stage 3C and 4A. This already happened in the 8th edition, but we decided to keep these two tumors in separate stages because their expansion, their tumor extent is different. 3C represents local regional disease and stage 4A represents metastatic disease. There are two ways of tumor dissemination, of anatomic tumor extension, and TNM is pure anatomy, so we have to pay attention to anatomy. And 3C and 4A represent different forms of anatomic extent of the tumor. For the pathologic staging, the same thing. The survival is very similar to the survival of the 8th edition TNM. The survival lines separate, they don't cross each other, and there is the same worsening of prognosis from stage 1A to stage 3C. And all the comparisons are statistically significant here. These findings were further analyzed in different subgroups, in different populations. Here we have two different ways to submit the cases, electronic data capture system and the batch data sets. We also compare squamous versus non-squamous. We compare the different regions, Asia, Europe, North America, rest of the world, performance status, 0 versus more than 1, the year of diagnosis, and the therapy, the treatment modality. In all of these populations, the stages that I have shown you make sense. There is a consistent ordering both in clinical and pathologic stage groups. I will not show you all the graphs for these populations, but I will show you just two for you to see how the survival curves behave in these patient populations. We have here the EDC, electronic data capture system, in the clinical staging and the pathologic staging. And here we have the batch data in clinical and pathologic staging. And you can see that the graphs are very similar. The stages that we proposed make sense. There are little differences from one graph to the other, but in general, these stages can be validated within these two types of populations, EDC and batch data, both at clinical and pathologic staging. And in this slide, I show you the squamous cell carcinoma and non-squamous. Here the clinical survival, and here the pathologic survival graphs. You can see that also that the different survival graphs make sense. There is separation of most of tumors, and this is the same in all populations that we have studied. Finally, what we did was to validate the 9th edition stages in the 8th edition database. And this graph shows the pathologic stages of the 9th edition using the patients of the 8th edition. And you can see again how well the survival curves separate. There is no overlap or approximation of the survival curves. And in this case, all the comparisons were statistically different. And you can see again the expected worsening of survival from stage 1A to stage 3C, from 85% to 8%. So these new stages seem to make sense in all the populations that we have studied and also in the patients of the 8th edition TNM. We did another analysis to confirm or to validate the separation, the division that we suggested for the 8th edition of stage 1A. We created stage 1A1, 1A2, and 1A3 to accommodate the new T1 categories, T1A, T1B, and T1C. And you can see here that both at clinical and pathologic staging, the three survival curves separate very well among them and separate well from stage 1B. So the innovation that we introduced in the 9th edition makes sense also in the 9th edition database. So for the 9th edition, we will keep this subdivision of stage 1A into 1, 2, and 3 for T1A, T1B, and T1C tumors, both at clinical and pathologic staging. There is one more innovation in the 9th edition. In 2015, Cadota and colleagues from the Memorial Sloan Kettering Cancer Center studied the prognostic implication of the cells, tumor cells, that spread through the air spaces, STAS, spread through air spaces. And they found that in those patients with very small adenocarcinomas, up to 2 centimeters in largest dimension, if the patient underwent a sublobar resection, the recurrence rate was significantly greater than in those patients without the STAS. So those patients who had the STAS and sublobar resection had more recurrences than those patients with sublobar resections and without the STAS. They didn't found this difference in patients who underwent lobectomy. So this article triggered the alarm in the oncological society, and many papers were published after this one. There are a few dozen papers, including all sizes, all tumor types, neuroendocrine tumors, squamous cell carcinoma, small cell carcinoma, and the general conclusion is that the presence of STAS in the specimen is associated to poor prognosis. In this paper, just published a few days ago, there are many tables and many survival graphs, but I just want to show you one. And you can see here that recurrence-free survival and overall survival is significantly worse in those patients whose tumors present STAS. If there are STAS, prognosis is worse. You probably know that the pathology community is a little bit divided about what STAS is. A group of pathologists think that it is a true form of tumor dissemination, but others think that it is just an artifact. However, we have this thesis and the antithesis. The synthesis of all this discussion is that whatever it is, the presence of STAS has worse prognosis. And because the evidence is very strong in the 9th edition database, we have recommended to add STAS as a histopathological descriptor. STAS X will be that it cannot be determined. STAS 0, there are no STAS, and STAS 1, there are STAS. So this is another innovation of the 9th edition. So what are the practical implications of all this? First of all, the 9th edition helps us refine the prognosis of a certain patient with a tumor of a certain anatomic extent. We understand better the prognostic impact of tumor extent by using the 9th edition TNM classification. However, the 9th edition TNM classification will be useful only if we perform a precise clinical and pathologic staging. That means that if we want to identify single M2 preoperatively, and if we perform an EBUS and only puncture one lymph node, the one that is big or positive on PET scan, probably we will not identify single M2 well. If we do not count the lymph nodes, the nodal stations that we remove at pathologic staging intraoperatively, or if we don't count the number of metastases and we don't locate them by the organ, we won't be able to separate M1C1 from M1C2. So it is important to insist on a very precise clinical and pathologic staging. And then we have to be very careful when we plan treatment. We have to be very thoughtful, because the question will be this: how are we going to treat T1 and 2A? Now it is 2B. It used to be 3A in the 8th edition. So how are we going to treat it? Well, the important thing that we stressed already in the 7th edition, these two papers were written for the 7th edition because some tumors change from one stage to the other, and there was some confusion about how to treat these tumors that change from one stage to the other. And the conclusion is that a change in classification does not mean a change in therapy. So all the clinical trials that we have for N2 disease do not separate N2A and N2B. So we have to treat N2A as we treated N2 until we have newer trials specifically designed to stratify tumors according to their N2 subcategories, N2A and N2B. Otherwise, we will be doing some therapy that cannot be supported by the evidence. This does not mean that you can operate on a single N2A patient if your multidisciplinary tumor committee decides on that, but there is no evidence to perform upfront surgery for any type of N2, right? So this is important to have in mind in our discussions of N2 disease in the MDTs. So the summary is this. There are no changes in the T component. The N2 will be divided into N2A, I repeat, single N2 station, and N2B, multiple N2 stations involved. The M1C will be divided into M1C1, multiple extrathoracic metastases in a single organ system, and M1C2, multiple extrathoracic metastases in multiple organ systems. T1 and 2A has been moved from stage 3A to stage 2B. Also, I didn't mention this before, I forgot, I'm sorry, but T1N1 in the 9th edition has been found to have better prognosis than stage 2B, so it has been assigned to stage 2A. T2 and 2B has been moved from stage 3A to stage 3B because it has worse prognosis than stage 3A. And T3 and 2A has been moved from stage 3B to stage 3A. This is very interesting because we already know that in the absence of metastasis, nodal disease leads prognosis. And we can see here small t, T2, with a big amount of nodal disease has worse prognosis, right? But a big T, T3, with smaller amount of nodal disease has better prognosis. So again, nodal disease leads prognosis, and the amount of nodal disease is important for prognosis. And finally, we will have this new histopathologic descriptor, STAS, that will be together with perineural invasion, vascular invasion, lymphatic permeability that are already in the TNM classification. So now we will have one more histopathologic descriptor. What can we conclude from all of this? Well, as I mentioned before, the 9th edition TNM for lung cancer refines prognosis, but only if we do a proper clinical and pathologic staging. Only if we do a detailed clinical and pathologic staging, we will benefit from the innovations of the 9th edition TNM, both in clinical practice and in research. So this is important. This is a very important message. We have to be as thorough as possible in the clinical and in pathologic staging. Finally, I want to show you the ISLC staging project within the frame of the whole history of the TNM classification. The first TNM classification for lung cancer was published in 1966 in the form of a brochure. So we have had lung cancer TNM for nearly 60 years. And we have had the ISLC staging project for nearly 30 years, which is more than half of the history of the ISLC, which this year will be 50 years old, and we will celebrate the 50th anniversary in San Diego during the World Conference of Lung Cancer. So in San Diego, we will finish this phase 3 of the ISLC staging project, and Valerie Roche will become the chair of the next phase of the project, leading to the 10th edition. And Dr. Osaro Yakbon will be chair-elect and will be chair of the phase 5, leading to the 11th edition. So I think that there is a good future in front of us to develop a better TNM classification, especially in combination with other prognostic factors such as clinical, geographical, but most importantly, molecular factors. We'll try to do this in the 10th edition and in the 11th edition. Thank you very much for your attention.
Thank you very much, Rami Porta. This was very informative and enlightening speech, and there was a lot of information about the 9th edition of TNM classification. And we have some questions from audience. Sorry. First question from Dr. Yekta Altemur Mustafaoğlu. Should total diameter or invasive diameter be more important in NIV staging?
Yes, this is a general rule in the TNM classification that has been applied to lung cancer when the part solid tumors were defined and were included in the WHO classification. So in part solid tumors that are usually adenocarcinomas, the size that counts for the T category is the size of the solid component. We have, for registration purposes, we have to register both the whole tumor size and the size of the solid component. But for the T category, only the size of the solid component counts. Yes.
Thank you very much. Buğra, you can ask the other question.
Yeah, sure. So it's actually Dr. Kara Mustafaoğlu asking the question, and I'm still the same question for you. After we performing the segmentectomy or sublobar resection, and we know that the GCO publication shows us the segmentectomy is a much more better survival compared with lobectomy, but we don't have any data at this task. And right now we know that's the worst prognostic factor. And how can we cure these patients? Because recurrence is common in those with this TAS positive patients.
Yes, this is a very important question for which we have no answer that we can base on evidence. However, I think that if you find the STAS in your segmentectomy specimen, you have to consider patient by patient. If the patient can undergo a completion lobectomy because the lung function is good, the patient is young, then you can propose to the patient, you can explain, look, there is this phenomenon, you have cells scattered in the air spaces, and this has been shown that it increases recurrence. If the patient has to know this, and then you can help him to make a decision on what he wants to do. If the patient cannot undergo completion lobectomy, I think that the best option is to follow the patient closely, maybe by CT, and see if there is any change in the suture line or in the segmentectomy line. If there is some growth or some scar that grows then you have to diagnose that and maybe propose alternative therapies like radiotherapy or radiofrequency for that lesion if there is a recurrence. So I think we don't have data. Not all patients with STAS have recurrent cancer. There is a higher rate of recurrence, but not all of them recur. So I think that because we don't have clinical trials, we have to consider patient by patient.
And thank you for your answer. And go on.
You can,
I'm sorry.
you can go on. Again, Dr. Yekta Altemur Mustafaoğlu asking a question. The station lymph nodes 5 and 6 is not like other N2 stations. So is it considered that these lymph nodes should be classified as N1 in new staging TNM classification?
Yes. We studied this in the previous editions of the TNM classification. The only thing that we found is that the stations 5 and 6 tended to have better prognosis, but compare with other N2 stations, but differences were not statistically significant. So I think we don't have data enough to reclassify number 5 and number 6 as N1. The evidence favors N2, although we can consider that it is a better N2 than other nodal stations. It is the same with the subcarinal. In the previous studies, we found that the subcarinal nodal station tended to have worse prognosis, but the differences were not significant. So it is still N2, but maybe it has worse prognosis than 4R, for example.
And our colleagues, Dr.Dr. are asking that, is the survival different in the old stages in the squamous and non-squamous lung cancer patients? Which one is the worst survival?
Yes, we should look at the graphs. There are minor differences between the stages in both squamous and non-squamous, but now I don't remember by heart which stages are worse than other. I think that this is already published, so you can access the JTO and you can look at the different graphs. I showed those graphs just to have a visual impression that the survival lines make sense in those different populations. But it is true that sometimes in some populations there are no statistically significant differences between two stages, for example. But in general, the stages that we propose make sense in all those 6 different populations that we have studied.
Thank you very much. There is a question from Bedrettin Yıldızeli. He says, great talk, thank you. His question is about staging of lung cancer after neoadjuvant therapy. Is there any proposition about that?
Very interesting question. In the 9th edition, it is the first time that we have analyzed with some detail the tumors that have received induction therapy. And we have pathologic stages for those tumors that underwent induction therapy. The survival graphs are different from those for pathologic staging of tumors without induction. So I think that this is a good point to consider in the future. For esophageal cancer in the 8th edition, we have 2 different sets of pathologic stages. We have pathologic stages for tumors without induction and a different set for tumors with induction. And I think that as we give induction therapy more often now with chemo, radio, immunotherapy, we will need these specific stage groups for tumors who receive induction therapy. Survival in most stages is worse than the survival of pathologic stages without induction, because we are already at the beginning, we have tumors that are more advanced. That's why we gave them induction therapy. So the pathologic staging, the YP stages, have worse prognosis than the P stages. There is a paragraph in the stages paper about this, but I'm sure that this will deserve more analysis in the 10th edition TNM.
Thank you.
And Dr. Karadeniz, she asking that what should we pay attention to when we recommending the surgery in oligometastatic patients?
Yes. Well, not all oligometastatic disease can be resected. I think the idea of the oligometastatic definition is that these oligometastases can be treated by some form of local therapy. Many of them by surgery, if it is adrenal or brain or lung, but others can be treated with stereotactic radiotherapy, with radiofrequency, with microwaves. So I think that the most important thing is that the objective of therapy in oligometastatic disease is to do a complete resection of the metastasis. I don't think that we should go for a partial resection of metastasis, or at least we should aim at treating them completely. If we cannot resect one of the metastases, we should try to do stereotactic radiotherapy or other therapy, because the idea of this oligometastatic definition is that we should treat them radically. And, well, we still have a few studies, we don't have trials, but from different series, we can perceive that it is worth to try to treat them as completely as possible.
And Dr. Porta, I want to ask you that, is there any change in the multiple primary lung cancers, synchronous or metachronous lung cancers in the 9th edition?
No, we have not analyzed the cancers with multiple lesions yet, because we have been so busy with the basic papers that we will have to consider that in the future. And we also need some more funding to do further analysis, because we have almost exhausted all the funding that we had for the 9th edition. So those patients with multiple lesions are reserved, are there, and we will analyze them when we have time and money. Yes. So far, the recommendation to classify lung cancers with multiple lesions are the same that we proposed in the 8th edition.
Yes, thank you. There is another question from Dr. Fatma Keskin Uzundere. Where would you position lymphangitic spread in the TNM classification? In the future, could a TNM classification shaped by molecular tests be possible?
Let's see, because it's important to understand that the TNM classification is an anatomic classification. So if we mix things, I think it will be very confusing. Mixing is not the same as combining. We can do the TNM classification the best that we can with the patient, and then we can combine all this information with other information. For example, nowadays, we all have in mind that an adenocarcinoma, stage 4 adenocarcinoma, with or without EGFR mutations, are different tumors. Anatomy is the same, stage 4. Biology is different, EGFR positive, EGFR negative. The EGFR positive tumor can be treated because we have specific therapy for that. The other has no specific therapies, just chemotherapy, right? So these are two tumors, but same anatomy. I think that it would be very confusing if we added the EGFR to the M1 descriptors, like contralateral nodules, pleural invasion, pleural nodules, pericardial nodules, EGFR. That would be like mixing different types of units. So it's better to keep TNM on one side and molecular data on the other and combine them to decide the best therapy for that patient and to venture a more precise prognosis. So adenocarcinoma stage 4 with EGFR is a different tumor because of the molecular data that has a different therapy from the stage 4 adeno without EGFR mutation.
Thank you.
And our participant, Dr. Kara Mustafaoğlu, asking that there's a lots of different N2 subgroups like skip N2, and also there's a publications showed us that extracapsular and microscopic N2 in the tumor staging. So is there any change or in the future stagings about the extracapsular pathologic N2 or microscopic N2?
Not in the 9th edition, maybe in the future if we have data on that. It is true that there are several ways to classify nodal disease. The TNM up to the 8th edition has only classified nodal disease by the anatomic location of the lymph nodes, which is a very simple classification, but it goes well with the anatomy. TNM is anatomy, so the anatomic location of the nodes fits well in the TNM. Now we know that quantification of nodal disease has prognostic impact, and N1, N2A, and N2B is just a different anatomic classification also. Is the amount of nodal disease, which is also anatomy. It's like tumor size. So nodal size, one is big and one is smaller. The extracapsular invasion is very difficult to determine preoperatively. Of course, you can do a thoracoscopy or a mediastinoscopy. You can remove the lymph node and the pathologist can tell you if there is extracapsular or not. But I think it would be too complicated to include it in the TNM classification because it is very difficult to assess preoperatively. And the size of the tumor, the size of the node would also be prognostic. It's not the same prognosis to have microscopic disease inside the node or bulky disease. But again, this is very difficult to classify and to include in the TNM classification. So for the moment, we only have this separation of N2 disease.
Thank you
N1 disease can also be separated, but we only have those data from pathologic staging. When we want to validate it at clinical staging, we cannot do it because it is very difficult to determine if N1 is single station or multiple. That's why we did not include it in the 9th edition.
Thank you very much. Dr. Talat Kılıç asking a question. Doesn't the presence of brain metastasis in the M classification worsen the prognosis compared to other organ metastasis?
Yes, there are some metastases that are worse than others. But, and this is very well described in the M paper, but again, sometimes you find some survival in clinical staging, and then it is different from pathologic staging. That's why in general, we have excluded the surgical metastases from the analysis because they represent highly selected patients. But it is true that, for example, liver metastasis or bone metastasis have worse prognosis than adrenal metastasis, for example. And brain metastasis can be treated in many ways. It can be surgically resected, can be treated by SBRT, if they are small and single or just one or two. So it is true that not all metastases are the same, but we don't have hard data to make prognostic groups up to now. Maybe in the future when we have more cases.
And thank you, Porta, for all of your speech. I think all our questions is right now finished. And we are thank you for our Astro Society to organize this event. And this is the incredible honor for us to listening to new lung cancer staging to Dr. Professor Ramon Porta. I hope this new staging will come and activate soon. Thank you.
Well, thank you very much for having me. It's been a pleasure to talk to you, and I thank you for the invitation. Thank you very much again.
Very much.
Okay. Bye-bye.
Thank you.